Malaysia was one of the earliest and fastest countries to roll out the COVID vaccine boosters even prior to the advent of Omicron, which became dominant sometime around early February in Malaysia. So what this means is that for policymakers, there was a burning question. Given the advent of Omicron, are the boosters that were just administered still as effective as intended? So to address this question, we conducted a two-part study. First, a test narrative design to study marginal effectiveness against infection, benchmark against primary BNT162b2 mRNA Pfizer primary vaccination. Secondly, a retrospective cohort to study the effectiveness, marginal effectiveness against ICU admission and deaths due to COVID. We use data that is nationally comprehensive, consolidated from several administrative data sets, including contact tracing, vaccination outcomes, to account as a proxy for exposure risk. The comparison groups in this study are those who are 0 to 3 months after their booster doses, and those who are 4 to 6 months after the primary vaccination, which makes them eligible for the booster doses, except that they have not taken the boosters, most likely due to supply constraints. Now, there is we can't discount that there's a large degree of confounding, which is why we adjust for a wide variety of variables, including detailed lists of reported comorbidities and proxies of health-seeking behavior, and also exposure risk. Replication files for the infection part of the study can be found on GitHub here. Before the analysis, we need to figure out when the Omicron-Dominant period likely began, which we drew from a related study that we conducted earlier in the year, which used a structural breakpoint test to estimate that it's most likely on the 5th of February in Malaysia. The second part is to have a breakdown of the comorbidities, prevalence of comorbidities in Malaysia by both the vaccination group and by age group. Nothing too surprising. They're higher diabetes and cardiovascular diseases amongst the older age group, lower amongst the younger age groups, but asthma seems to be rather higher for the seems to be rather higher for the younger age groups versus cardiovascular diseases. The first set of the VE findings then find two things. One, the marginal effectiveness reduced substantially, almost half in most instances, moving from a Delta to Omicron period. Second one is that heterologous boosting offered more protection than homologous boosting. That is, if you receive a different type of vaccine for your booster than your primary vaccination. The second set of the VE findings are on the severe outcomes. Here, again, there is some degree of reduction in marginal effectiveness moving from the Omicron Delta period to the Omicron period from left to right. But the split between the heterologous and homologous vaccines are not so clear-cut. But thirdly, but quite importantly, what we find is that for the individuals who receive primary inactivated vaccines, regardless of what boosters they receive, what type of boosters receive, effectiveness seems to be lower for these groups of individuals than those with 3 doses of mRNA, Pfizer in this case, and those who were primed with the viral vector vaccines, AstraZeneca, AZD1222. So what this means is that boosters still demonstrated exceptional protection against severe outcomes, but close surveillance is warranted to ensure that protection is still adequate in the environment of endemicity, so that especially amongst those who are demonstrated lower vaccine effectiveness, the lower real world protection, and those individuals with major comorbidities. Thank you.